Welcome back to the Physio Foundations podcast, where we talk about the knowledge and skills that provide the foundation of expert clinical practice. So my guest for this episode is the one and only Tania Pizzari. So Tania's an associate professor in the Department of Physiotherapy at La Trobe University and a member of the La Trobe Sport and Exercise Medicine Research Centre, the director of Mill Park Physiotherapy here in Melbourne, Australia. And Tania's an internationally recognised educator and researcher. You probably know about her already, but if you don't, you will find out about her as you make your journey through your clinical professional development as a physiotherapist. Say if you're a student at the moment, this might be the first time you hear from Tania. Tania has a special interest in, and you can correct me in a minute, Tania, if you've got more special interest, soft tissue injuries, including the calf complex in footballers, injuries in children, and of course, shoulders, which is going to be the topic of today's chat. Tania spent a lot of time at the pointy end of physiotherapy research and clinical practice, but the focus today is going to be on the foundational knowledge and skills that she's built her expertise on top of. And we're not going to simplify things here for the sake of it. The focus here is making sure we build those strong foundations in thinking and knowledge and skills that you can build your expertise upon. So let's bring her on. Tania Pizzari, welcome to Physio Foundations.
Thanks, Luke. That was a great introduction. Great to hear.
Anything I missed, though?
Oh, no, that was pretty comprehensive, I think. I definitely have an interest in all of those things and I guess continued learning and continued interest in lots of things, but definitely clinically, I mostly treat shoulder injuries, and then research-wise, lots of soft tissue, calf, hammy, quad. But yes, definitely a great introduction. Thank you. Thanks for having me.
That's great. Great to have you on the podcast. So I'm sure people will get a lot out of this chat. Let's talk about shoulders. Let's talk about the main categories of shoulder conditions. So obviously we can explore the pectoral girdle too, and we don't have to drill down too much here. Let's keep it fairly broad. Obviously, acute injuries, fractures and instabilities, dislocations, load-related conditions. Yeah. How do you frame everything, all the pathologies in the shoulder?
Yeah, I mean, it's a difficult joint, which is probably why I love it so much. I think very, very simply, when you look at the literature, we were discussing Bruckner and Kahn before coming on, but, if you look at those kind of, if the way that they categorize the shoulder injuries and sometimes can be helpful, but we will discuss a little bit more why that can sometimes also be unhelpful. But you kind of have, as you mentioned, your instabilities, so your glenohumeral joint instabilities. Obviously, you can have AC and the sternoclavicular joint as well. But if we focus mainly around that glenohumeral joint, there's kind of instabilities. It can be traumatic, it can be atraumatic, and we can work through that a little bit more. You do have your AC joint pathologies. That is generally a category around the shoulder in the literature. Then you have more the stiffness type pathologies, so your glenohumeral joint, so your intra-articular type pathologies, so really commonly OA, and frozen shoulder in that category. And then you have the big category of rotator cuff or subacromial pain. So in some literature, it'll be called just rotator cuff tendinopathy, and everything gets put into that. And in other literature, it'll be subacromial pain, and again, everything gets put into that. The other category that's important, I think, is the neck, and that's obviously not the shoulder, but that's kind of your biggest differential diagnosis and can be really tricky in the early stages. Even for me now, it can be difficult to know, are you treating a neck, are you treating a shoulder? You're probably treating both in a lot of situations. There's a saying that I've heard many times, if you're treating a neck, you're treating a shoulder. If you're treating a shoulder, you're treating a neck. So they often do go hand in hand. But, what's the primary driver of the person's presentation? Is it the neck? Is it the shoulder? And which one are you going to address first? So they're basically the categories that it can be useful to think about. So instability, AC joint, glenohumeral joint, so that includes your frozen shoulder and your OA, and then your rotator cuff tendinopathy, which is a big is a big category. So that includes all of your rotator cuff pathologies, your calcific tendinopathies, your tears. It includes degenerative tears. It can include acute tears. Your bursitis, if you want to use that as a diagnosis, which can also be a little bit controversial. Long-headed biceps is included. In the literature, they would include even slap lesions in that category, although I would argue potentially that should also be considered in your instability category as well. But they're kind of your main categories that can be useful to think about in terms of shoulder. The reason that sometimes it's not necessarily all that useful to categorize into those separate entities is, well, first of all, as we discussed as I noted with the neck, is that they can be intertwined a lot of the time. So, if you see someone with an atraumatic instability, for example, they often do have a lot of rotator cuff pathology. They may, as I mentioned, have some slap pathology. And so there's a lot of crossover between those categories. It's very unusual to kind of see someone with who fits very discreetly into those categories, probably with the exception of, your OA type category and your frozen shoulder. They tend to be a little bit more discreet, although they can still have other pathologies on top of those. So sometimes, rather than thinking about shoulders specifically in each category, it can be useful to look more at like a movement systems paradigm. So looking at more the biomechanics of the shoulder and particularly for atraumatic shoulder pain. If it's a traumatic shoulder condition, then those categories are a little bit easier to understand, to comprehend. So you've dislocated your shoulder, or you've sprained your AC joint, or you've fractured something, and it's kind of a little bit easier to understand the direction of your management. Whereas if someone comes in and sits down and says, I've got shoulder pain, I have no idea why, and they're a 25-year-old male who goes to the gym, and you're thinking, okay, like what could possibly be the cause of that? And we don't necessarily have great understanding of, as in the whole body, what's the pain generator? But, around the shoulder, is it a tendon? Is it the bursa? Is it a joint? Is it something completely different? Is it neuropathic? Is it psychosocial? Like there's all these things that can come into play. So the way that I like to look at atraumatic shoulder pain is using a movement system sort of diagnostic paradigm, which there is literature on, but it's essentially looking at the biomechanics of the shoulder. So how is the shoulder actually moving? So in particular, looking at the scapula, is there really commonly you'll see sort of insufficient upward rotation. And if you don't have sufficient upward rotation, for example, the humeral head is not sitting well within the glenoid. And so that can set up, some atraumatic instability type symptoms. It does put a lot more stress on your rotator cuff because the cuff is really having to hold that humeral head in like not the best position because it's not sitting right in the glenoid. So you're putting extra load on the cuff, for example, just by having insufficient upward rotation. Your cuff, the length tension relationship of your cuff is impacted if your scapula is not moving in the best biomechanical way. So, looking at something like that, looking at the tilt of, you see a lot of people with insufficient scapular posterior tilt. So most of us are in this anterior tilted, downwardly rotated position, and it's not the greatest position for the humeral head to sit and located in the glenoid and for the rotator cuff to function really well. So looking at things like that, looking at how the scapula is moving, how the humeral head is positioned. So, do you have hypomobility of the humeral head as you would see in a frozen shoulder or in an OA type population? Or do you have hypermobility of the humeral head? So is there excessive translation, which you commonly see in those younger people, particularly who are presenting with atraumatic shoulder pain. So if you're looking at how someone's actually moving, how the scapula is moving, what the humeral head's doing, and then identifying if there's deficits in that, and if there are, can you change those deficits? And you can try and do this immediately. So can you do, Jeremy Lewis would call it a scapular modification or a humeral head modification. Can you do some biomechanical modification? Like we call it a correction. If you do Lynn Watson course or read some of the literature with that Lynn's involved with and myself, we talk about, can you correct that biomechanical deficit of the scapula or the humeral head and make an immediate change in your patient? Because then that gives you a really nice, it's a great marketing tool, but it gives you an understanding of what's going to help that patient and whether physio, in fact, is going to help that patient too. So it gives you a good indicator of what you need to do for your rehabilitation, essentially. I know I've talked a lot, but that's kind of
I don't want
how
to
I'll
interrupt.
generally look at a shoulder. So yeah. So is there any deficiencies? Can you change those deficiencies immediately? And there's sometimes you can't, but you may identify that over time you will be able to change that. And is that part of the patient's solution?
There's a lot in that, and that's really helpful, a really fantastic overview. So if I'm summarising there, the diagnostic categories are really useful for those acute injuries, instabilities, fractures, acute instabilities, dislocations.
Yep.
And it may be beneficial to think more about a movement system approach for those atraumatic conditions where we think there's a lot of contributing factors, biomechanics,
Yep.
and then you mentioned other contributing factors as well. Non-biological, psychosocial,
Yep.
for example.
Yeah.
So you mentioned that would be you said marketing tool, marketing for the patient. You can say, hey, look at this. If you change this, there's instant change in your symptoms. There's something in this. And getting buy-in from the person for their rehab rather than them thinking, well, weeks from now, maybe it will feel better. You can have instant change in symptoms.
Yeah. Yeah, I do find that a really strong convincer that the person needs to do their exercises, and yes, that actually you should perhaps come and see me again whenever you decide, because we're on the right track here. I've got the solution to your problem. It's not dissimilar to putting tape on to somebody's patellofemoral joint and getting them to do another, an asterisk that they were having problems with, a squat, and then they go, hang on, this is much better. So I use that a lot particularly for atraumatic shoulder pain. It can be used for traumatic, just to get a set. Obviously you're still looking for any deficiencies that you could assist with. But yeah, it is a fantastic marketing tool. And I say to my patient, sometimes we're really surprised that I've put my hands on or I've done something and now they can lift their arm and it's not painful. And you say, look, what we need to do is just teach your muscles to do what my hands are doing. Or, sometimes I use taping. So if it's a dynamic type movement, that I can't, that it's dangerous for me to, I'm not going to get under somebody snatching weights and try and modify what they're doing, but maybe I can use taping to try and get the scapula into a position or the humeral head into a certain position, then get them to do the activity again. And if it immediately changes their symptoms, normally the symptoms are pain, but it could be neurological symptoms. It could be subluxations. It could be just, clicking, cracking, clunking that they're not happy about. And so if you can change those immediately, then, as I said, it just provides the patient with a lot of confidence that you understand what's going on, even if you don't know what the pain generator is. So that's really important. So it may be a number of things, the cuff's overloaded, the labrum's being, compressed with their translational instability or whatever the problem might be. You may not know what the pain generator is, but you know the solution to their problem, and you can really sell that to them. And that can be, a fantastic marketing tool.
So people don't necessarily come in determined to have a pathoanatomical diagnosis as much as wanting to know what the solution is, and seeing the immediate change can be really powerful. Yeah.
Yeah, look, I think people do come in wanting a pathoanatomical diagnosis, and that can be tricky because obviously we have to be careful of language and causing, catastrophizing
Right.
and impacting that psychosocial element. And particularly, if the person's had the pain for a long time, or it's impacting their life quite considerably, which a lot of shoulder pain does. People lose sleep, they can't do their activity they want to do. They might even have pain just sitting at the computer at work. So it can have big impact on people's lives. So we do have to be careful. But sometimes if you don't give somebody a pathoanatomical diagnosis, that can cause issues too. So it's kind of getting a balance between saying, I know the solution to your problem. Don't worry about what's going on. Like, I don't want to give you any information. You've got to balance that with the person's desire to understand what's going on, to be able to tell their boss, oh, it's this, or work cover, or it's this, or their mum and dad, this is the problem. If they kind of go home and say, oh, I've got insufficient upward rotation of my scapula and I need to posteriorly tilt more, and there's a little bit of translate, they're not, that's not enough, that's not great for people. So, like, without causing any psychosocial distress, it is important that they have a pathoanatomical or something that they can pin. There's great research done by people in Melbourne from Monash, where you are, Luke, looking at that the terminology and the use of certain words, particularly with shoulder, and that there's evidence that if you use things like obviously tear and even impingement, that causes a much more distress than saying bursitis or a sprain. Like, you've sprained your shoulder. Like, people accept that for ankle, but we would never say that really for shoulder. But maybe we should be saying terms that people are comfortable with and understand that it's not the end of the world. It's not such a big deal, and it's kind of giving them something but not
Yeah.
causing that distress, I think, is really important.
And tied into that is diagnosing what it isn't as well. So
Yes,
ruling out your red flag. So the neck, don't
absolutely.
forget the neck. You said
Yes.
earlier, and that can contribute to the difficulty of diagnosing and changing symptoms when the neck's
Yes.
contributing to it directly or indirectly.
Yep.
And then what about what are some red flags, some general baddies, things that we could be ruling out? That could be something you can say, hey, look, there are a number of contributing structures in here, but the main pattern of movement is causing it is this and that. And by the way, good news, we've ruled out some serious pathologies here, and I think that it will respond to the exercise we're doing. That's a good start for
Yeah.
someone to de-escalate fears. So what red flags should the students and new grads and anyone listening to this
Yeah.
always try to rule out, do you think?
Oh, look, I think the usual kind of red flags of, any kind of thoughts about tumors or,
Yep.
cancers and things like that. So if people are having, significant night pain that's kind of unexplained, and they've had some weight loss and that sort of thing, and fevers, or anything that really you think, I'm not too sure about this. I'm not sure that it's actually their shoulder. I think that, that's obviously um, something to consider and send back to their GP for some diagnostics. Certainly, if there's been acute trauma, that somebody has had. A fall is really common in an older population, but, thinking about your younger population, a sporting kind of activity, that they're important to investigate potentially a little bit more, or to have in the back of your mind. Do we have an acute fracture, or do we have, and in terms of a fracture, like, even if it's post-dislocation, you have sort of a bony Bankart lesion or a Hill Sachs, things like that are not like terribly concerning. So they're not sort of, oh my God, you need to go to emergency. But fractures around the scapula, fractures around the clavicle, even the humeral head, they may require obviously require some orthopedic opinion. Infections,
Yeah.
again, I think you need to be aware of.
Have you seen some of them pop up just out of the blue
I
in your
Interesting,
lengthy experience?
yeah, they're not common at
Yeah.
all around the shoulder, but probably the ones that I've seen a lot of that maybe the younger physios and students may not be so aware of is something called SIRVA, so SIRVA, which is shoulder injury related to vaccine administration. So I see a few of these a year, usually post flu vaccines, but during COVID, I saw heaps more post COVID vaccines. So it is considered generally to be related to the wrong kind of an incorrect administration of a vaccine, so that maybe they go up a little bit too high in the deltoid and hit the subacromial subdeltoid bursa, and that creates kind of a cascade of an inflammatory response within the shoulder. But in fact, there's a little bit of evidence to show that it's not necessarily just because it hits the bursa. It there is sometimes the infiltrate. It can infiltrate the agent can actually infiltrate through the deltoid and into the shoulder and irritate the synovium and get a really solid sort of almost like an infection response. So it's not an infection, but everything's just inflamed. So they kind of present like a sudden onset of frozen shoulder. Like they can't lift their arm. Everything's painful, terrible night pain. It generally settles down. But it can take kind of 4 or 6 weeks to really settle. But I do see a couple of those a year. So look
Okay.
out for that as well.
All right. Well, I hadn't heard of that. So SIRVA, we've got
Server,
the abbreviation there,
yep.
and the definition. So there are things that crop up every now and again that we shouldn't miss. But the things
I
we're
think
seeing
the other one would be
on.
like neuropathies. Again,
Right.
quite uncommon. But if something's not fitting, they have often a gradual onset or maybe a sudden onset, but the muscle's just not working. So, they can't lift their arm. You're thinking there's something strange here, particularly in a younger person, then I'd be concerned about that as well.
Suprascapular nerve.
Yeah, suprascapular nerve is the common one. Long thoracic nerve can happen as well. You don't see them commonly, but they do happen.
And whether that's post-viral or post-infection or a medical cause, but
yeah, it can be a loading biomechanical cause too. Like you'll sometimes see it in the most. I think I saw a couple last year where it was the carpenter who is carrying heavy loads on their shoulder, wood and things like that, ladders and just that sort of compression through the shoulder and that stretch through the shoulder. So keep that in mind as well.
Let's talk about assessment, physical examination, but which we've been doing anyway. We could really maybe if we take it back, we've ruled out serious, sinister pathologies and diagnoses, or at least identified them. How to think about broadly categorizing shoulders into the acute and the less acute, also atraumatic, and thought about the movements that might contribute to them. Now you're doing your assessment. At university, you learn everything, and then you need to try to think about, well, what physical examination will I do in the short amount of time I've got with this person? How do you approach that broadly with the different types of presentations that come in? You don't just do all the tests on everyone every time. It's targeted by what you're hearing and
for sure. And I think that's the key thing. And obviously, as you progress through your university and through your career, you'll get much, much better at this. But, oftentimes by the end of the subjective, hopefully you're pretty sure what's going on. Like in a lot of situations, you're just confirming what you're thinking based on what they're telling you in the subjective. Sometimes it surprises you. Like sometimes it still surprises me. Like I think, I know exactly what's going on. And then you do a few tests and you go, oh, actually, they're not as positive as I thought they would be. Or, there's another couple of tests that are, and you sort of change your position. But majority of times you get to the end of the subjective and you're deciding, okay, I'm going to do X, Y, and Z just to confirm what I'm thinking. I think the the way that I generally approach, I still do active movement tests just to almost get a bit of a baseline as well. So, what are they do? Where are they at the moment? And how far are they away from where they need to be? But the key thing about your active movement test, I'm not generally I'm not getting out my goniometer and measuring. I'm not doing overpressures on things. I'm not sure if we still teach that in the undergrad program, but I'm watching how they're moving. So, going back to that movement systems paradigm, I'm looking at what the scapula is doing, what the humeral head's doing, recording, approximate sort of range, where they start to feel their pain, what limits their end of range. And then really importantly, can I change it? So if I've watched them do, say, a flexion, they're only getting to 120, limited, maybe they think by pain, they just don't want to go any further. Can I actually help them facilitate the scapula? Can I reposition where that humeral head is, and does that improve their range of motion? Same with abduction, same with external rotation, hand behind back. They're probably the key active movement tests that I'll look at. So flexion, abduction, external rotation, hand behind back. I don't generally worry too much about extension, or I'll look at your horizontal type movements like horizontal flexion, extension, if I think there's a posterior instability, for example. But if you're thinking it's rotator cuff type pathology, you're probably not going to look at those in an initial examination. And then again, sometimes post you're doing that, you have a really good understanding of, confirming what you're thinking after the subjective. I do use rotator cuff tests. I know, there's a lot of they've been much maligned in the literature, I suppose. And, Jeremy Lewis would say we need to put them out to pasture. But I think it's basically been in some ways, our not misinterpretation of the findings, but I think we can do more with the findings. That's what I would say. So, they are pain provocation tests. You can get a sense of strength as well. But the critical thing for me is, if you do say an empty can, I don't do empty can and full can and think that can differentiate a supraspinatus. So I think that's been our interpretation, or the teachings of that along the way, has been that, yes, if you do full can, there's less superactivity. If you do empty can and that's more positive, yada, yada. That's where we get into trouble about interpreting. So I would do an empty can because it does load your cuff quite a lot. So you get a sense of, is there a problem with loading the cuff in that position? But then the critical thing is, can I change it? Can I change those symptoms? So, can I block the translation posteriorly? Because someone with a posterior instability doesn't like that position either. They hate it. So if I block them posteriorly of the humeral head, and then I do the test again, and now it's not so positive, or it's not positive at all, they get no pain, then I know their cuff is actually fine. It's really just that excessive translation that's overloading their cuff. And then again, I've got the solution to that person's problem.
So using your hands or tape. If they're
using
in a
your
position
hands,
you can't,
normally for that position, it's easy just to pop your hands on. But yeah, absolutely. Similarly, if it's an older population, they're getting problems with that empty can position, can I reposition the shoulder blade, the scapula? Can I just hold the humeral head down away from the acromion a little bit at the front? Can I reposition that scapula and humeral head and get a change in that empty can? Because again, if I can, then I know that the cuff is okay. Like it's grumpy, it's inflamed, it's unhappy, but I'm pretty sure then I can kind of help them to change that. And I know that there's not necessarily, a big full thickness clinically relevant tear. If someone can't hold into an empty can, has a lag with external rotation, really struggles to elevate their arm, maybe then are looking at a clinically relevant tear. So that's, they're the kind of things that I would use the rotator cuff testing for. So I think it still has relevance in your clinical exam. It's just how you interpret it. Don't over-interpret. Oh, full can means this, empty can means this, external rotation means this. Don't over-interpret it, and then can you change it? Like that's really the most critical part. Can you modify the symptoms on those tests?
Well, diagnostic validity, in which tests like that are criticised, are yes, no for a
Yeah,
diagnosis,
yeah,
and they're not including the elements of changing the translation of the humerus and the scapular
yeah.
position. So
Correct.
it's really,
And changing
yeah,
strength and things like that as well. So, can you actually, classic one, if your listeners want to try is, looking at just external rotation. How strong are you in external rotation? You could use a dyno, you can just use your manual muscle testing. Then, get the person into an upwardly rotated, posteriorly tilted scapula, and then getting them to do it again, and does it change their strength? Even in a normal population, similar thing in 90-90, so up in 90 degrees, people are pretty weak with external rotation here. You know, you can test it on yourselves, measure it. Then can you then hold the humeral head at the front? So just do a buffer at the front, really hold that humeral head, and then do it again. And even in your normals, you will find a change in strength just by stabilizing the humeral head anteriorly. So, I think if we just play a little bit more with trying to change the symptoms that these, pain provocation tests provide, then or produce, then we can improve that diagnostic accuracy. We can improve their not even so much the accuracy, but what they give us in terms of diagnosis and the solution to the problem.
we're really thinking about a binary test, yes, no, for a pathology,
Yeah.
and thinking about transitioning that to a reasoning about prognosis. And
Yes.
it strikes me
Yeah.
that in the way you practice, you're bringing in the education really quite early. The
Yeah.
ubiquitous patient education thrown in there at the end as a bit of a lecture. No, this is actually about showing someone from the beginning what you're
Yeah.
doing, what you're testing,
Yeah.
what you're finding,
Absolutely.
what it means, how it could change, and getting that buy-in from the beginning.
Yeah.
I just wanted
Yeah.
to make that really
Absolutely.
overt that is what we talk with patient education.
Yeah.
It's the difference between just doing it all in your head and then trying to give them a summary at the end versus showing them and
Yeah.
building it into the
Absolutely.
rehab from the beginning, from the assessment.
Yeah, absolutely. Because the other thing you can use, is cueing. So rather than just use your hands to get, okay, now I want you to hold your shoulder blade up and back for me. And then while you do that movement, does that change it for you? And so, that again helps start the conversation when you're about to give them an exercise or, talk about posture. And you can use that, remember when I got you to do this and it felt a lot better, that's kind of what we need you to do in your everyday life. And so, yeah, education is really from the start. And I think that doing it in that movement systems approach helps with that rather than, like you say, you're doing all these tests, push against me here. Oh, is that painful? Yes. Push against me here. Yes. Is that painful? Oh, yeah. And then going through and the patient's thinking, what are you doing? Like you're just testing all these things. I don't understand what you're doing. And it's causing me pain as well. But if you can then modify their pain, then like we were mentioning before, they really have a lot of confidence that you actually know what the problem is almost from the get-go. Like I had a patient yesterday who seen lots of different people, which is not uncommon for my patients, but she had this shoulder pain, and she'd had an SC, which is odd, but she'd had an SC to an injection of corticosteroid, and that helped with her movement. As I said, as you could just whack corticosteroid into her toe and it'd probably help with her movement, just reducing the inflammation in her body. But she still had her pain. And she was kind of, traveled a long way, and she was kind of a little bit distraught because the pain hadn't improved. And, from the outset, from the subjective, I thought I knew what was going on. It was a posterior instability. I did a movement, I corrected the movement, and she just said, "Oh my God, you know what's wrong, don't you?" And I said, "Yeah, I think I'm pretty sure I know what's wrong. We'll test another few things." And just from the, that instant test, the thing that I did, she was just like buzzing that someone finally knew what was happening and could potentially help her. So yeah, it was interesting.
Potentially others did know as well, but the approach, how you educated and showed her how the symptoms could change may have been the
Yeah.
difference. Or look, maybe they didn't know what they were talking about. I always like to give my colleagues a little bit of credit as
Yeah.
well, because
Yeah.
they've come to you not necessarily through failure of everything that they've seen in the health professional before them. It just the problem's still going, and you are an expert, so they've ended up
Yeah.
with you.
Yeah.
And the difference there may have been how you're showing them.
Yeah.
Can I change it is a big theme here.
Yeah, absolutely. Can you change it? Very
That's
strong.
really good. What shoulder conditions or presentations do you still find challenging even after all your years of research and teaching and clinical experience?
Yeah.
People say the shoulder is complex and challenging. We always say that. And
Yeah.
then some things are relatively simple and they do have a good prognosis, and others are really challenging. So where does this challenge come from?
Yeah, it's a good question. I think it's one of the most challenging populations is the ones that do have that concurrent sort of neck pain and, degenerative changes, and, there's lots going on. Everything's quite inflamed. They're, often maybe metabolically quite unhealthy as well. So
Yeah.
yeah, there's a real sense that they're just in an inflammatory state. And the shoulder seems to be, a common location, as evidenced by frozen shoulder, a common location where metabolic health seems to be important. I think postmenopausal, we know that you're much more likely to have rotator cuff pathologies and things like that postmenopausally. So, metabolic stuff is really important for shoulder. So the tricky ones are, that they're kind of, I call them, they've got a grotty neck, the shoulder's sore, they've got rotator cuff tendinopathy, they're generally in this low-grade inflammatory state. I find they can be really challenging because, you kind of can do all the right things, but you're limited in what you can do from that real metabolic kind of cause, and then from that chronic neck kind of degenerative changes, and they can be tricky. And
Yeah.
you have to focus on neck, and you have to focus on shoulder, and then you're trying to give a little bit of health advice, and they're still challenging even for me.
Okay, so but this is really important to reflect on if you're a student or a new grad or an up-and-coming clinician. You're listening to Tania and you're reading all her research, and you've been to her courses and read her contributions to the Bruckner and Kahn textbook and all of this stuff, and you think, oh, okay, well, I'll send this difficult, challenging presentation person to Tania, and she's having trouble managing this person.
Yeah.
And so it may not, you may have done everything right. And
Yeah.
and that's something that we should acknowledge. And so that contribution of the metabolic health, postmenopausal status as well, is, I guess, advice to zoom back out and have a look at the whole person as well. And you mentioned all the psychosocial factors and their work and sport and hobbies and everything else that they're doing and loading them up.
Yeah.
Look at the whole person.
Yeah. And I think the other thing, that's much more common in the upper limb than the lower is that central sensitization. So I think part of the reason, like say tendon pathology in the lower limb, it's less likely that you can still have kinesiophobia and that central kind of hyperactivity and that sensitization, but it's much more common in the upper limb tendons. And that may be because you can't get away from it as easily as in the lower limb. If you've got an Achilles or a patellar problem in the lower limb, just don't jump or don't run or don't do the thing that causes that pain. And generally, you have those periods where it's not sore. Whereas in the upper limb, it's much less common. We're all, you have to use your upper limb, and the cause of that tendon pain is not necessarily overload. Well, it is overload, but it's not necessarily because you painted your house or you've done too much overhead sport. It often is just postural. So, if you're downwardly rotated and your humeral head's not sitting in your glenoid, your rotator cuff are under tension. So they're under this tensile load the whole time. And they wrap around the humeral head. So they're under this compressive load too. And we know that tensile and compressive loads together are kind of what starts the cascade of tendinopathy. So, yeah, so with the upper limb, it's harder to get away from the pain. So it may be the reason that you do get more likely to get those central changes, and then they become tricky. You're not just treating the shoulder then, you're kind of treating the whole nervous system. And yeah, if you send that person to me, I'm going to have just as much trouble, trying to sort that out and help that person as anyone.
But then you may have a better start with that person if you start off with that education and thinking, can I change it, and being positive at the beginning rather than doing a whole series of tests, which they've already had done, and that reproduce pain and they don't really know why you're doing it. So that's been a big theme from this conversation.
Absolutely.
And you mentioned night pain earlier in the assessment, and maybe this presentation, the combination of the tensile and compressive loads and the constant need to use the shoulder contributes them to being more irritable and waking people at night. Then that affects your quality of life and sleep, and there's a cyclic cascade there. Yeah.
Absolutely.
Look, I guess the point of this conversation is to recognize these patterns and think out beyond just the following the routine of the testing that we're doing and trying to diagnose people, and thinking a bit more broadly about what's going on.
Yeah.
What was your, for the final penultimate question that you can go anywhere with, what do you think are the most important knowledge or skills for a health professional, specifically a physiotherapist?
Yeah. Oh, geez.
It's anything goes here.
Look, probably what I would say is the knowledge that you can always learn more.
Yeah.
I think, in my experience of having, young physios at the clinic, and I'm on the clinical panel at WorkSafe, so I talk to physios all the time. And the only time I get a little bit concerned about somebody is if they think they know everything. That really limits how much you will ever know and limits your thinking. Obviously, it's really nice to challenge your thinking, challenge your knowledge continually. Like, I think I've got a lot more to learn about shoulders, a lot more to learn about everything. And I think that holds you in good stead as a physio, as a health practitioner, as a person, really, that you can take new things on board and you can challenge yourself and you can continue to learn. So that's what I would basically say to the young physios out there and students, and just be careful about thinking you know everything, but also being stuck, in a room just with patient after patient after patient, and you can get pretty happy with that and feel like you're doing a good job. And look, you probably are for the majority of people, but challenge yourself to get out into the world, talk to other physios, go to do some courses, read lots, and keep learning.
What a great way to end it. Tania, thanks very much. That was I got a lot out of that, so I know the listeners will have as well. There's lots we can go and apply straight away in the clinic, but also to reflect on and think about in our practice and ongoing education, lifelong learning. That was a really good final answer. Where can people follow you to find out more about you and your work? Are you a bit of a ghost online, hiding from the trolls and just doing your high quality work?
No, I'm not great on social media, I must say. I've got Twitter, like at Dr. Tania Pizzari. I don't have Instagram. And yeah, I'm not that fantastic. I think my clinic does have Instagram, not that I'm on there, but yeah. Anyway, just look up some articles, or happy for people to email me as well if they need articles and they can't, they're behind paywalls and things. Very happy for people to reach out and I can shoot things through.
Great, that's really generous. And yeah, there's a lot of reading they can do. So they can find out all about your work on Google Scholar. And if you can't find the papers, of course, ask colleagues, ask Tania directly, chat to you at conferences, courses, for example.
Yeah.
On that topic, anything upcoming you want people to know about? I know you've been on the learn.physio. We not a sponsor. They probably should be. With Randall and me. I'm still paying my full subscription fee for practicals. But we've both been on that platform, which is really good. You've got your shoulder masterclass on there. But that type of stuff. Anything else that's coming up you'd want people to know about?
Would probably, I do a lot of this kind of thing, and if people want to find it, they can, I guess, learn.physio. And obviously I teach here at La Trobe and our postgrad courses. So if anyone is interested in any of the postgrad space, so we obviously do a sports and exercise masters and a musculoskeletal masters, and so we have some webinars and things about those. But yeah, very happy. I'm sort of the head of those, lead those. So if anyone wants further information, they can grab me. Looking for controls for an fMRI study for in multidirectional instability, female controls. So anyone with good shoulders out there, young between I think 18 and 35, and you'd like to have a scan of your brain, let me know. But yeah, other than that.
Yeah, that's perfect. So that's a really good way to get involved in research, meet the researchers themselves. A low, I guess, effort. Maybe you have to go in for a couple of hours or something, and then you get quite a lot out of it.
It's been like an hour MRI, and you just do a few movements in the scanner. So we're interested in, first of all, the difference between multi-directional instability, what's happening in the brain, just with movement, and then we're doing some pre-post rehabilitation with the MDI population. So that'll be really interesting. But yeah, we're just after our last few controls.
I can really endorse that. If you're a busy clinician, you are interested in meeting people beyond the conferences, and you want to contribute to research, just helping out as a control or contributing in some way to clinical research can be a really good way to meet people.
Yeah. Actually, on that, I think apart from getting a gift card, there's the opportunity to do some shadowing with myself or Sarah Warby, who's obviously another great shoulder physio. So we're doing the research together. And if anyone volunteers to do the study, we're opening that to, if you wanted to shadow for half a day or something, then that's available to people. So yeah, if you're interested, let us know.
What a good opportunity. People are always asking me, how do you get opportunities like that? And you just ask, really.
You do.
That's it. You talk to people and you ask them questions, and they ask you questions.
Volunteer for things, and
things happen.
Yeah,
it's not necessarily going to be advertised.
Yes.
So, great. Well, there you go. Hopefully the last few controls contact you today.
Thank you.
So look, really valuable, and the profession is so much better for having you and your work so humble as well, the way you approach everything. So thanks, Tania.
Thank you. That's very kind.
And for the listeners, good to have you back on the podcast for this year, and thanks for joining us in the conversation. But the podcast is obviously free to you. Like I joked about before, no sponsors. It's part of my wider academic work. So I do hope you're finding the episodes helpful. And if you are, the best thing you can do is find the little share button and send it to a friend, put it onto your channels internally. And I don't do any other call to action other than just, if you're finding it helpful, do share the episodes around, and that helps us get these positive messages for our profession out to people who need them. You can see video versions of some of the podcast episodes on the Periton Physio YouTube channel, and we've got some plans to load some more interesting video content on that this year. So have a look at that. And most importantly, good luck with your own clinical work and management of people with shoulder conditions. I know that you probably got something really useful out of that conversation, because I did. So thanks, Tania, again.
Thanks, Luke.
So until next time, this is Tania Pizzari and Luke Periton wishing you all the very best with your studying, professional development and lifelong learning.